In terms of treatment and management, there is no current specific treatment for hepatitis A infection. Instead, symptomatic treatment is the mainstay of HIV management, along with sufficient sanitation in order to prevent further spread of the virus. So the treatment is more supportive, which includes appropriate rest, balanced nutrition, and avoiding hepatotoxins like acetaminophen and alcohol. The best protection against hepatitis A virus is prevention through immunization. Vaccines are readily available here in North America, but not as much in the developing countries. Hospitalization is required when patients develop changes in mental status, also known as encephalopathy, worsening liver enzymes, and increasing levels of bilirubin and prothrombin time. In the past years, viral hepatitis is considered to be a major cause of acute liver failure. Acetaminophen toxicity has now become the number one cause of ALF. However, ALF related to HIV infection is still considered a potentially lethal illness, even though it's not common. As mentioned earlier, hospitalization is required when an infected individual's condition continues to worsen, particularly with encephalopathy, as this may be a sign of acute liver failure. Others may have prolonged or relapsing course of the illness, which happens to about 20 to 30% of the infected individuals. But this does not mean that they will develop ALF, but advanced age and other comorbid conditions increases the risk of developing acute liver failure. So once it develops, the individuals often require an emergent liver transplant, or it may lead to death. Recent publications have often cited HIV infection as a frequent cause of liver failure that requires liver transplantation. Although hepatitis A is not a significant cause of ALF in North America, it is still a threat in major parts of the world, other major parts of the world, like certain parts of Asia. It has even been predicted by some experts that acute liver failure related to hepatitis A virus may increase in these areas in the future as more individuals, particularly the older population, become more and more susceptible.
We will now talk about the treatment methods that are available for fulminant hepatic failure. Treatment options include liver transplantation or extracorporeal support. Please refer to the liver transplant video listed in the comments section. Please be aware that the content may be graphic. Keep in mind that treatment options will depend on the symptoms that the clients present with, as well as the severity of the disease. However, research shows that the most common treatment options are transplantation and extracorporeal support. Liver transplantation is the most successful treatment available for patients who have been diagnosed with fulminant hepatic failure. However, many considerations need to be made prior to listing. Considerations include whether the patient has adequate social support following the transplantation, whether the patient will be able to manage their medications, as well as whether the patient will even be able to afford the costly immunosuppressant drugs. According to Toronto General Hospital's Liver Transplant Manual, other assessment data that are collected during the evaluation process for transplantation include the client's blood type, whether they have had previous blood transfusions, any comorbidities the clients may have, as well as a thorough assessment on whether the healthcare team believes the client will be able to survive the invasive surgery. The following slide is a chart that will give a better idea of all that needs to be considered during the evaluation process. A liver transplant assessment can take as long as 3 months. However, in cases of fulminant hepatic failure, an expedited assessment, which often needs to be completed within days, is completed due to the acuity of the situation. In situations such as these, FHF patients who have been accepted as liver transplant candidates are listed at a status 3F or 4F. Normally, the Trillium Gift of Life Network is the organization responsible for designating organs to citizens of Ontario only. However, in cases where a patient is listed as a status 3F or 4F, any liver that becomes available in Canada will be given to that patient. The following slide is a table that illustrates all of the statuses assigned to liver transplant recipients in Canada. Following transplant, clients will need to undergo lifelong immunosuppression with a combination of a variety of drugs, which can lead to an entire list of complications. Other limitations include the availability of a donor, costly immunosuppressant drugs, as well as complications that can often follow surgery, such as infection and sepsis. However, liver transplantation remains the gold standard in cases of fulminant hepatic failure. Extracorporeal support. Although liver transplantation has proven to be the most definitive method to treating fulminant hepatic failure, there are several limitations that exist. As stated earlier, the availability of a donor liver in a timely manner is a major limitation, as well as the fact that the patient will need to undergo lifelong immunosuppression. Due to these limitations, many believe that the use of extracorporeal support may work as either a bridge to recovery or a bridge to transplantation. Although there are several types of extracorporeal treatment methods available, for the purposes of this presentation, I will only focus on two of the most promising types of treatment. The molecular adsorbance recirculating system, or MARS, is a non-cell-based system that uses albumin, which can bind to hepatotoxins to support the failing liver during FHF. Essentially, blood is removed from the body where it enters the MARS membrane, where 20% human albumin acts as a dialysate. Toxins are then thought to bind to the albumin dialysate. These toxins are then carried to the dialysis membrane, where toxins are removed from the blood through hemodialysis before returning to the human body. The following slide is a diagram that illustrates exactly how MARS works. Although this system looks very promising, there is still a lot of research that needs to be done before this particular type of treatment is used more widely. Also, it is important to keep in mind that with many of the studies that were conducted to test the effectiveness of MARS, as soon as an organ became available, patients were immediately taken off MARS and transplanted. Therefore, it is still difficult to determine whether MARS is more effective than transplantation. Furthermore, although MARS has not primarily been used as a way to treat FHF alone, it has often been used in conjunction with transplantation, branding it as a bridge to transplantation. The extracorporeal liver assist device, or ELAD, is a cell-based system that uses immortalized human C3a hepatocytes to support the liver when a patient is experiencing FHF. With ELAD, the patient is connected to the ELAD system with a double-lumen hemodialysis catheter, which is inserted into a vein for central access. Blood is then drawn from the patient at a rate of 200 mL per minute. Ultrafiltrate, which separates plasma from cellular components and is a solution used in ELAD, is pumped into an environmentally controlled chamber which contains the ELAD cartridges. While cellular components are returned to the body, the ultrafiltrate containing plasma are carried to 4 ELAD cartridges. Each ELAD cartridge contains approximately 100 grams of C3a hepatocyte cells, which detoxify the ultrafiltrate when it is passed through. Glucose is also added to the ELAD cartridges to match the consumption rate of the cartridges during this process. An oxygenator has also been put in place to ensure that the hepatocytes have access to a continual oxygen supply. 2 cell filters are also placed in the ultrafiltrate return line, which reunites the now detoxified ultrafiltrate with the cellular components of blood before returning to the body. The following slide is a diagram to help you better understand how the ELAD system operates.